And I hope you had a nice sort of Christmas and break and managed to get some rest. Firstly, I will do a very quick round of introductions before we start. My name is Councillor Lily Bath, and I am the Cabinet Member for Adult Social Care, Public Health and Health Integration. And in my Cabinet Member role, I chair the Health and Wellbeing Board. Thank you. I'll go to my right.
Hello, I'm Chaspal Sandhu from Democratic Services.
Good evening, I'm Stephen Ford, I'm Executive Director for Children's and Adult Services here at the Council.
Hi, Dr. Armin Gupta, Primary Care Representative and Hounslow Borough Medical Director.
And I'm Chris Hilton, the Chief Operating Officer for West London Trust, Mental Health and Community Services.
Hi, and I'm Sheena Busnight, Managing Director at West Mid.
Hello, I'm Anne Phillips, Senior Public Health Officer. Hi, Claire Miller, what's my title today? Clinical Director for Hounslow, West London Trust.
Very good evening. Peter Goulding, Chair, Health Watch, Hounslow.
Hello, Sterling Rippey, Principal Public Health Strategist.
And I'm Paul Prober, I'm the Council's Head of Policy and Insight.
Good evening, and I'm Martin Waddington. I'm the Borough Director for Hounslow for the North West London ICB and the Director of Commissioning for the Council.
Thank you, everyone. I also want to take the opportunity to welcome anyone who might be joining online. It's a horrible evening outside, raining, so it's nothing better to do than to watch the Health and Wellbeing Board meeting. But anyway, let's start then. Any apologies for absence? I haven't. None have been brought to my attention, unless anybody. I believe Councillor Chowdhury and Councillor Sue Sampson are coming, but they may well be running late. There's been a little bit of confusion around times, and I have to apologise about that. But I'll look into why it all happened, because I know you told me you've all had different timings for the meeting. No, okay, so no other apologies. In that case, can we move on to the minutes of the last meeting? And what I might do is do minutes and matters arising together, if that's okay, just for saving some time. So if we go to page 7, if you can do accuracy first, please sort of let me know if there's anything that needs correcting. Any matters arising on page 7? No. Page 8. Page 9. Page 10. Page 11. Page 12. Page 13. I've got something here under action, and I know it's not going to be an action that we're going to be able to put into place very quickly, but it was really about reviewing the support available for the last part of patients' lives, and we said that we'd relook at that in the new year. I just want to make sure, obviously, we don't lose sight of that. So does anybody have any feedback on that?
So Councillor Bath, there is a lot of work happening. Chris Hilton, Stephen Forbes, myself are involved in that work, so we can make sure that it's on the agenda for the next meeting. Yep. Great.
No, that's absolutely fine. I didn't expect there to suddenly be a marked improvement, but as long as we don't lose sight of that and there's work being done to it, that's fine. Okay, page 14. No. Page 15. In that case, I can sign those as an accurate record, and we'll move on to agenda item 3. Is that you, Ben?
I am, yes.
Ah, right. We've never met before. That's why I'm asking you, Ben. Welcome. Okay. So I know you've just arrived, Ben. Are you sort of ready?
I'm always ready on Hounslow Care Together.
Okay, brilliant. Okay, I'm really looking forward to this, because this is a really exciting new project that we agreed at not that long ago, and it'd be really interesting to hear how we're getting on with it. You've got presentation, have you? Yeah. Okay. Thank you very much.
So when we started this project around a year ago, we reviewed some very substantial work that had been done by PwC for partners in Hounslow on care for frail older people, and it identified some fundamental problems which are very common across health and care systems, not at all unique to Hounslow. It identified limited proactive support for people to maintain their health, a lack of intensive joined-up support for people when they tip into frailty or crisis, restrictive criteria and waiting times, delayed discharges, multiple referrals across many different services and transitions. We argued, looking at this work, that the fundamental problems we faced were the lack of a good model of generalist continuity-based care for people with long-term needs. And the second big problem was an incredibly fragmented system with possibly over 100 small different health and care services for frail older people alone. And we argued that the solution we needed to home in on was a small team model of multidisciplinary care, aligned and rooted as close as possible to our core general practice. And we argued that this model, which is well evidenced around the world, would allow us to restore relationships, continuity. It would allow us to reduce the bureaucracy and the transaction costs of a system where people get transferred between lots of different services, and it could help us to restore accountability because we would create small teams that would hold the vast majority of people's care for a defined group of people and could be held accountable for some meaningful improvements in their quality of life. In September, we launched 2 test projects, 2 core multidisciplinary teams, one at Maswell Park Health Centre, one at Heart of Hounslow. So there's a core team of a community nurse, a district a community matron nurse, a social support worker, a community health worker, and a few other people. And these teams are supported by an extended team of a pharmacist, a social worker, housing support officer, community connectors, occupational therapists, and others. And we went through a really intensive process to get to this point. We brought together staff from across our system. We met fortnightly for development sessions. We learned from successful examples of this type of team model across the country and internationally. So we launched our teams in September. So they've been operating for a little bit more than 3 months now. We started with a long list of 2,000 patients for 6 GP practices at these 2 health centres, and we focused initially on people with the highest levels of frailty because those are the people who have the greatest risk of avoidable hospital admissions. So it's the cohort where we've got the greatest chance of showing in hopefully the relatively short term that we can significantly improve people's care, but also have a significant impact on avoidable health and care costs. So the GPs selected the patients from our long list that they believe would most benefit from the team support. So this is the enrolled cohort that we have as of mid-December. So by mid-December, and of course the numbers have gone up since then, teams had enrolled 56 patients, staff had visited and assessed all exposed patients and were developing their care plans. It's a predominantly older population, most are 80 or older. They're all people with severe frailty or moderate frailty on the Rockwood score. They're all people who visit their GP practice a huge amount, who have visited, most of them have visited A&E many times in the last few years. Most have had at least 1 hospital admission over the last 2 years. And it's very interesting if you have a look at the table showing their engagement with services before we enrolled them in the team. So they're all people who are known to our community services. They've all had some interaction with, for example, our district nursing services or our community crisis response services, but they're not known to many of the specialist services that we've set up. for example, our full service or enhanced dementia care service or our mental health service. The vast majority are not known to adult social care. Very few have an advanced care plan. Pretty much nobody has a preferred place of death collected. And this is reassurance that we're on the right track, in so much that we're putting in place a service that is genuinely addressing a significant gap. We have a very fragmented, specialized system at the moment, but the people who need those services are not necessarily getting them. And we're really struggling with proactive planning of people's care before they tip into crisis. So very briefly, this is some staff feedback from the first learning session 6 weeks after launch. One of the case managers said, shouldn't this have happened years ago? There was a really consistent theme that staff were able to spend more time on direct patient care because they were sitting in a room with staff from other services right next to them, so they could look over the table and ask for support from an occupational therapist or a pharmacist or a social worker, rather than sending letters and referrals between different services and having those referrals potentially rejected. So very positive, and that very positive feedback has been a consistent feature over the last few months. Some other initial learning, it takes a long time to fully implement this type of service and get the full benefits, and we're finding that we have to continually iterate and improve the model of care. Homing in on the right patients has been more challenging than we expected, and it's continuing to be refined. We're still not fully using all of the staff members as well as we would like to, but I'm sure we're going to be able to do that in the next few months. There's lots of early learning on staff roles and team structures. There are challenges in mobilizing some of the support services, for example, our IT support for these teams. And there are challenges bringing, what we've done here is we brought staff together from 8 separate organizations into a single coherent team structure. And obviously there are challenges in doing that because they've all got their own procedures and working methods and contracts. So we have, and Sterling is leading this, we have a comprehensive framework for evaluating the model up until autumn of this year, focusing on self-reported health and well-being measures, patient and carer experience of care, staff experience. We really think that we can dramatically improve patients' experience of care if they get to know a small team who hold their care and take responsibility for supporting them rather than bouncing around the system. But equally, we really think that we can improve staff experience because staff are fed up working in a fragmented system where they spend a vast amount of their time transacting with other parts of the system. And finally, the big thing is we're focusing on measuring utilization of health and care services. And of course, decisions on whether to spread this model hinge upon us being able to show that we can really reduce avoidable health and care costs. So the next stage, the big focus now, apologies for this very busy slide, is our work program to develop a business case for spread. That includes a number of really important strands, working out staffing options for spreading the model across Hounslow at different levels of intensity. We didn't hire new staff for our test project. We were taking staff who were already working with people with complex needs across the system, within a PCN, and applying them in a new team structure and a new model of care. So we've always worked on the basis that we would be able to spread this model using our existing staff, but we now need a detailed proposal for doing that. We'll need to think through the future of affected services. So the plan here was always not simply to add something new to the system because the system is too complex, it's got too many services. It was to try and find a way of bringing things together and simplifying the system. But we'll need to work out exactly what services these teams can replace and what services would need to remain and in what form. There's a lot of work that we're doing developing our IT requirements for the system at scale. We'll need to think through payment and contractual and organizational form questions amongst other issues. And the plan is for us to work intensively on a business case for an initial business case to be reviewed in April. I'll stop there, Councillor Bath, if that's okay.
Yeah, thank you. Thank you very much, Ben. That's really interesting, and obviously we absolutely support this model of work, of the way of working. And it's interesting to hear some of the early findings. Just for my understanding, going back to that evaluation metrics slide, do we have any in terms of utilisation, health and care services? I know I know it's very early days yet, so I appreciate that. But do we have some understanding of whether there's less visits to A&E or less hospital stays or something? Or is that too early to tell now?
Anecdotally, so at the moment, I think the most, and Sterling may well wish to contribute because she's the expert on this, but I'll start if that's useful. At the moment, we're at an early stage. And the most useful information I think that we can present is actually through patient case studies. And when we look at I've just been reviewing 3 of them today. When we look at them, that gives me a reasonable degree of confidence that we're making some tangible progress, because these are case studies of people who interact with the system through many different routes, struggle to get the care they need, and therefore interact more with the system, and they're now dealing with a single nurse case manager. So I'm optimistic that that data will come through. The most obvious opportunity is we ought to see a reduction in GP appointments, because these patients are having lots of GP appointments. So I would have thought that relatively quickly we ought to be able to see that unnecessary GP appointments are going down. A&E admission, again, people having relatively regular visits to A&E. So again, I'm hoping that that could be shown in the relatively near future. And then things like hospital stays, I'm a little more worried about, because it may take longer for that positive data to show up. At the moment, bluntly, we have enrolled relatively cautiously because we need to do this safely. And the teams are still getting used to a new working method, working with a whole group of new team members, developing and testing their procedures as they go. So we've gone cautiously. And at the moment, we're 3 months in, and probably only a couple of tens of those patients have been enrolled for the full 3 months.
You want to add, Sterling? Yeah.
Yes, if I can. I think following on what Ben just said, actually, is I think there was only 10 patients that started within the first month. So they've just reached a point of 3 months of activity. So we'll begin to look at, we allowed kind of three months for the intervention to take effect and have the impact, and we'll begin to measure those patients' data. We're also comparing the outcomes of their experiences to similar patients in other cohorts. How we develop that is kind of a work in progress, but we'll be able to kind of compare in some form of a cohort of people who have similar complexities but aren't experiencing this, what's happening to them, and then these patients. So hopefully over the next kind of 3 months, we'll begin to see that.
I'll open up to questions now. Peter?
Chair, thank you very much indeed, Ben, and for Sterling. I was focusing on the 56 patients that we've got into the cohort out of the 2,000. On the long list, we've gone down to 56. And 52 of them have, 31 have got no advanced care plan, and 52, I think, said had not placed a preferred place of death. That's quite interesting, because it's just of a very, very small cohort. And I think the learning that we want to make from this is cross-checking and flowing to other projects like the end of life project that we're going to review later on. Here's a bit of core data. We've spent a lot of time around advanced care planning, but that's been focusing in care homes. And this is presumably hitting a cohort outside the care homes, but it is a problem. And if we could fix some of that system, it would help various projects. So here is a little nugget of information which would be very useful for another project. And it would be great if we could just fertilize that across and see what else we could do, not just in this one project. Thank you.
Thank you. Yeah, point taken. Yeah. And did you want to respond to that, Ben? Yeah.
Only that it's, I think it's a very good thought. Thank you. What this reveals for me is what we knew when we started, which is that we have in England systems that are fundamentally adapted to treatment when people fall over and arrive at health services. And we have services that are really not equipped for proactive care. So although it's a very small cohort, the 50, and it will go up, I'm hoping substantially over the next few months, it is the 50 most complex patients that we could find over in the patient lists of 6 GP practices. Those were the 50 that those GPs were most worried about, and almost none of them have advanced care planning. So it does tell us a vast amount about the opportunity to shift to a more proactive model of care.
And to make those established systems that should be working thoroughly embedded so they do work. And if they don't work, we got to fix what's wrong with those particular systems. But if we all agree that advanced planning, as an example, works well, then it's sort of making sure it's embedded. As you say, this is the critical group that we're looking at, the group that everybody is analysing and say they've got the greatest need, and we haven't quite got it right for them. So what about the rest of the 2,000? It's going to be.
Any other questions from anybody else? Christopher.
Thank you, Chair. Not a question, but just a comment, if I may. I guess from a community and mental health trust perspective, but also through the lens of the borough-based partnership, I think it's important to think of the work that we're doing here as testing a different way of neighbourhood working that starts to try and shift away from a transactional model of referral in, receive an intervention, be discharged, to a more relational and continuous care model, more akin to how primary care operates, but with a selection of patients that we're hoping will most likely benefit from our services. From a trust perspective, I think one of the challenges that we have debated as we are piloting this initiative is the degree to which we are confident that this service, with expertise from a multidisciplinary team that's together, can replace a whole range of other services that may be being provided for an individual family. So we're trying to build the confidence that we have the expertise and capacity in order to stand down some of the other pathways. But where individual families and patients are receiving good care already, that's something that we're very cautious not to perturb. Hence the need for a robust evaluation as we go along, before we think about, can we press go on this as a model of integrated working across more of our neighbourhoods in Hounslow. So I think we're excited about it, but keen to make sure that it fits within the ecosystem that we have, which is fragile sometimes.
Thank you. And just a thought from me, I'm assuming we want to roll this out, don't we? How close would we be to that? I know you showed us a slide with some time frames and things.
So I think by April, we'll be able to review an initial business case that makes the main arguments and for spread, and can quantify at least a high level the investment that would be required. I have various worries, I'm sure that everybody else does, about how far we will have answered some of the questions by April. Particularly, there's a very good evidence base internationally that this team model outperforms the siloed, fragmented specialist service type model, but we have to prove that we can do it in Hounslow and demonstrate the benefits that we can achieve here through the model. And I'm hoping that we'll have at least some of that information coming through by April. And then the proposal would be to revisit a more detailed business case before the summer, and to make a final decision to start spreading the model in September.
Thank you very much. Well, I'm very in support of this model, and I really do hope that it does take off. And I know this is just for information, but it would be good to get you back. I don't know what the committee feels, to get some feedback in a few months' time. We'll have you back again and see how it's going. Yeah. Okay. If there's no further questions, I can't see anybody indicating they'll move on to the next agenda item. Thank you very much. Yeah, and good luck with all the work that you do going forward. Okay, so the next agenda item is agenda item 4, and it's Hounslow Health and Wellbeing Strategy, and it's an update on the refresh on our strategy. And Anne, are you going to start? Yeah, thank you.
Yes, Councillor Barr, thank you. This is just a brief update for you for the board to let you know where we are with the refresh on the health and wellbeing strategy, which is due for renewal this year. We have been through a course of a whole year of engagement. We've been to area forums. We've been on the main agenda at the area forums. We've also created a video and shared that through our networks and on the YouTube channel. We've done a survey. We've interviewed and surveyed young children and young people in our borough, over 162 in actual fact. And we've engaged with our key health and wellbeing stakeholders as well. We are just reviewing now with the engagement that we've done, the health and wellbeing priorities. You can see on this slide that we've got youth aspirations for what that will look like in 2050 for when these people that we interviewed reach the age of 45 to 50. We've got some strategic themes coming out too. But the main reason, in the majority of the slides that I've shared with you already, you can review at your leisure, or if you haven't already, that's the key themes that are coming out from the early years and families. And the headings are actually through send and educational support as well. So there's a varying degree of information that we've shared with you. But the key thing for us now is we are getting to the point where, too far. We are getting to the point where we're reaching phase 2 of our development. We are going now into February and June, where we're thinking of now drafting the document, drafting the finalised, as you can see, and then sent to the designer, and then the design stage. That's where we're heading to now. So we've completed the whole year of engagement. We've had some really good feedback from our residents, which we've shared with you. And interesting now to see what the next stage of that will be as we go through this part of the year. That's where we're at, Councillor Bath.
Okay, thank you. I have to say, from my experience, the consultation feedback from residents at area forums was quite good, actually. That was the first time we did that, and it's really good to look at health and wellbeing in the wider context from what people are actually saying in their neighbourhood. So I think that worked really well. But any questions from anyone or comments? No? Peter?
Chair, thank you very much indeed. I'm looking at the primary care and NHS services and looking at the key takeaways, and later on I'll refer back to it when I get to the patient experience survey in a later agenda item. There are themes that are consistently coming out. It comes out in the patient experience survey. It's coming out in this. It's about appointments. It's about availability. It's about the challenges. It's about specialist care wait times. It's about improved patient experience. It's about mental health. It's about more dental appointments. It's about end-of-life care. This is extremely good, but it's another piece of evidence that's building upon a lot of evidence we've already got of exactly where the community feels we need to focus, what their concerns are. And they're very, very consistent. And they're consistent in our current strategy. And it's clearly coming through that whatever we're doing now is not necessarily changing that much. Otherwise, the communities will be focusing on other things. They will be recognizing the change, and they're clearly not, because they're coming up with the same issues. And I guess as we move forward to the plans and then the actions, that's going to be our challenge, is what could we do? What are we able to do to try and change some of this? Otherwise, in another 5 years' time, we'll be having the same conversation, and none of us want to be in that position. We want to improve.
I think Peter's hit the spot. We didn't have anything new that came out of the engagement. It was all something that was current in the current strategy. So that's good for the going forward with the new strategy. And we're sticking to our themes of start well, live well, age well, and healthy places. So that will be consistent. We just obviously need to look at what those projects will be as we go forward through 2026, and obviously align that with the NHS 10-year plan and working with our partners in the ICB.
Thank you. Yeah, I mean, there isn't anything new, but then there will be very consistent. There'll be things coming up again and again, which we understand, but it's about how we address that. Any other questions or comments? Sterling.
Yeah, thank you. I wasn't at previous meetings, but I understand conversations have been about looking at a longer term strategy for exactly these reasons of the needs haven't shifted and the work takes a long time to do that. So as we look into the future strategy, we will look at a longer period so we can spend staff and officer and all of this collective time focusing on the delivery and maintaining continuous engagement to make sure nothing has changed, but taking on that point of making sure the kind of cycle is consistent with the amount of time to delivery. So I just wanted to follow up on that point.
No, it's a very good point you make, Peter. I guess if you look at just GP appointments, from when we did the strategy to today, I'm sure Amit could give us a full presentation and all the things we've done for improved access, engagement with yourselves. So I guess the question is, I believe we chose the right things. I think the tasks and what we've put in place, we believed were the right things. Whether the outcome was the result we wanted is a good question. Is it that the population's behaviours have changed? Because we really, I mean, I use GP appointments as one of the key issues of, if you talk to some GPs, they say there's enough appointments when you talk to other people. So I think what we will continue always doing, as we remain on this health and wellbeing, is that problem won't go away. I think people will always want to access their GPs, and there will always be a set of the population who don't think they can access them well enough. But if you look at a lot of the data that we produce, lots of people access their GPs very quickly, get the right resource, etc. So I think we have made improvements. I think we continue to need to make improvements, and so I'm pleased it's still a priority. But I wouldn't say we didn't do the right things for the last 4 years.
And if I can respond, Chair, I've not said we have been doing the wrong things in the last time. I'm just saying the challenge is still there. And the GP appointments is a difficult one, because you will always ask anybody and they'll always say, I want more appointments and I want it quicker and I don't want to wait. But if you look at that first one, for example, mental health services, that we know is a real challenge. And then we could just take out the health service completely, look at education, look at the number of exclusions, and I chair a number of the independent review panels on exclusions, and consistently SEND comes up, mental health comes up. Whether it's involved in the exclusion or not, it's sitting there in the background. It's still substantially an issue, and we know it's an issue, and it's not going to be fixed overnight. And we know the challenges are getting harder and difficult. So yes, I think we're hitting the right things. It's just a question of, when we move forward, what is it that we're going to be able to do to try and have a greater impact than what we have been able to do so far?
Thank you. I'm going to bring Claire in. Claire.
Yeah, it was just a comment about the item about the ADHD support for children and adults in these. None of the providers in-house are actually commissioned for providing ADHD diagnosis, let alone support to them pre or post diagnosis. So that is a commissioning issue that does need to be resolved. There was a commission service. It was an acute hospital, but they've closed their waiting lists.
Okay, thank you for sharing, and I'll formally record that, and we'll take that away. Just to further comment, really, on what Peter and Martin have said. I've been an elected member for a number of years, and some of these issues have come up. But for me, the big improvement is the fact that the way that we're engaging with people, we're getting a lot of better information out. It's a lot richer, and there are things that we are talking about a lot more for example, ADHD support for children and mental health, that perhaps we didn't do as much. And if we keep talking about them and keep having them on the agenda, it doesn't mean that we're not doing anything. It actually means that we are doing. And I'm quite, I feel quite strong about that, because as elected members, that's some of the things that we really wanted to have on the agenda, and we have done. And I've always talked to you about it, haven't I? I've always bent your ear, Martin, about this. So I think for me, that's a really good result, because we are talking, and we keep bringing it up and up and up until we do see. And I think there have been improvements, but there's always a lot more to do. But
Yeah, I just wanted to add on to the end of Claire's comments, which are correct. The commission service is not accepting new referrals, but I'm just worried that I don't want members of the public to think that they shouldn't approach their GP for diagnosis, because there are national right to choose services. So patients can seek the framework, choose a provider, which is not the North West London Commission service, and they can be referred to those services to receive a diagnostic service whilst our current commission service is closed. So just in case anybody's listening at home and are worried that they can't access a service, there are alternatives.
Okay, thank you. That's noted as well. I don't have any more questions or comments in that case. Thank you very much. Remind me, what's the next stage?
We're in the design stage now.
In that case, we'll move on then to, we're doing very quickly today, agenda item 5, Better Care update. This is the usual update that we have. And Martin's going to give us an update on the Better Care Fund.
Thank you very much, Councillor Bath. If you remember, at the last Health and Wellbeing Board, we did some detailed presentations on what the Better Care Fund delivers in Hounslow, so I'm not going to go into detail. Every quarter we need to do a response to NHS England, and that needs to be signed off by the Health and Wellbeing Board. So I hope you've all read all the documents in detail, and all I'm asking today is that you sign off a quarterly report for the Better Care Fund. Thanks very much.
Has everybody had an opportunity to look through it? Good, okay. In that case, if there are no comments or questions, I'll be happy to sign that off. I've looked through it, so happy to sign that off. Okay, thank you. We then move on to agenda item 6, which is the health and wellbeing strategy. And again, that's a progress report of Q2. And the information is in your agenda pack, but we'll have Sterling is going to update us on that.
Yes, thank you, Councillor Bath. I wanted to flag a few key updates across 3 projects, but you will be able to see all quarter reports across the various projects, of which we touched on a few from the last quarter around 0 to 4 A&E attendances and various other bits. 3 I want to bring today include 2 which are green and 1 which is amber. 1 is a good news story around the carer support. This is an area of where we've had more investment in the council, so we have additional officers working in the team, and that's led to much more activity available for carers. There's these officers started in the summer and have already started to deliver support hubs, free respite activities, very heavy community engagement activities across the borough, across community hubs, providing one-to-one advice, particularly on benefits, the short break service, which is available, the carers emergency card, etc. This activity is not just across community hubs, but events like Health in the Park, which was hosted with all health partners, as well as a table at the hospital twice monthly, engaging constantly with carers, and over the last 6 months, seeing already 363 and getting them supported across that quarter. So that was just activity across Q2, sorry. We have 1,778 carers subscribed to the fortnightly email, which is really positive news. And all of this is down to that those 3 staff members and that team really growing that activity. Over the next few months, as they continue to settle in, there's going to be a new carers advice line set up, a training program for unpaid carers, particularly around end-of-life care and manual handling. And that's really positive news as we've known the needs from our carers through the care needs assessment. The second one I wanted to update around was breastfeeding. So when we published the health and wellbeing strategy back in 2023, breastfeeding rates at the 6 to 8 week check was around 40%, 43%. And over the 3 years, that percentage has increased to 62.5%, just shy of the target, which is really, really good news story. This is due to a massive collaboration between investment from the family hubs, public health working more closely together, and some really innovative work around opening up spaces for mothers to access safe and comfortable spaces for breastfeeding through the breastfeeding strategic plan, but also drop and support a 6 days a week availability, which is really positively accepted, but we're hoping to roll it out to 7 days. There's also been a really focus on inequality, so looking at the inequalities in uptake of breastfeeding, particularly in our core 20 and equality opportunity areas. And finally, there has been a peer support group, which has been really, really well received, and people find that really successful. So the initiation rate is 93%, which is really positive, but we're looking at that 6 to 8 week point as a really key point of success, because that's after the baby and mum have gone home and settled in. The final one is an amber, but I think it's a really still good news story and has come to cabinet around the Housing First project. That's the 5 homes which are dedicated to those who are experiencing homelessness and providing that housing first option and then bringing in supported care. It's amber because of a delay due to the housing regulation inspection, but the project is moving again, and all of those who have been involved have been supported to find relevant accommodation if they've accepted it. But really what this brings is a housing first model where then our key partners like mental health, the ARC, substance use support, and adult social care can come collaboratively and comprehensive in. So these are just 3 I wanted to flag and provide some comments on, but happy to provide comments on others or take those questions back to the delivery leads. Thank you.
Thank you, Sterling, and some good successes there in carers and breastfeeding and homelessness as well. Any questions or comments at all? Do you want to share a little bit about some of the stuff you're going to do about the ambers? Yeah, it might be.
Yes, so there's some which are experiencing delays. If we take, for example, the immunization program, some of that has been delivery in terms of flu offers of a change in provider and things like that. So we're keeping a pretty close eye on those of which turn to amber and understanding with them. So Anne and Martha here meet with those project leads and understand what's happening to get a picture of it. They aren't off track, but they just might be experiencing a slight delay. So we aren't worried about any of the others. I think similar to the Housing First, it's either something's come in and delayed it by a few months, but we see progress. If not, we'd raise it as a red. But happy to answer any of them.
Thank you. That's really good to hear. Any questions? Councillor Chowdhury.
No, I was just going to say thank you very much. I was really happy to see. I know there are a few ambers, but I was really happy to see a lot of green as well. Thank you.
Okay, then in that case, we will move on to the next item of agenda. Thank you, Sterling, which is the Joint Strategic Needs, JSNA, Joint Strategic Needs Assessment. And Paul is going to give us an update on that.
Thank you very much indeed. The board will remember that you can approach JSNAs in a whole raft of different ways. Oh, maybe not. Thank you. There. Thanks, Martin.
Lots of sides.
As if it's literally that one. This is truly just a verbal update. So the board will remember that there are various ways that organisations can approach developing a joint strategic needs assessment. Historically, Hounslow went down the route of a PDF, but for the last 3 to 4 years, we've recognised that really didn't cut the mustard, and instead we've been using the Hounslow Data Hub, which everyone can access on stats.hounslow.gov.uk. That's accessible to anyone in the room, anyone watching online, any member of the public, any organisation across the borough, or anyone indeed with access to the internet. That gives us a flavour on a regular basis of updated, as near as dynamic, as near as live data as we can get for a whole raft of JSNA related content, both some of the more clinically focused and also more of the wider determinants of health as well. Now, I wanted just to run through a handful of bits and bobs that have been updated since we last met. And since Kasturi gave you an update back in, I think it was October. Community Assets Snapshots, that's one of our recently revised products showing what's going on across the borough in terms of, as the name suggests, community assets that organisations, charities and individuals can use. Again, you can pop online, you can play with that interactive maps, your heart's content, to understand what's available, where, what kind of asset, how that might be used. I think that lends itself to commissioners thinking about how you commission things where people are, rather than where you maybe commission things where you wish that people would go. So you can begin to use the assets that exist within the community rather than thinking about what you might put elsewhere and expect people to go there instead. So that's definitely worth the board's time having a quick look at that. We've also got some work linking into the wider determinants of health and well-being, looking at working from home patterns and looking on transport usage as well. Struck, although some of this is data that is a few years old, certainly in terms of the working from home analysis, we've combined both of those to kind of give a guidance, I guess, to help people think about where you might look at good quality work. So where do people have a degree of autonomy, a degree of flexibility about their working opportunities? Where have they, and the converse of that, where is there an expectation that people need to be somewhere typically doing work that pays a little less, to be candid? The transport usage, we've overlaid that on those working geographies. This is more up-to-date data from TfL that gives people an understanding of both what transport infrastructure is available and what's busy and what's used. I think when we were undertaking that analysis, we were struck by just how well used Feltham Station was, by way of an example, and yet how we so often think of Feltham as a place that's out at the end of the borough, and in reality you're 40 minutes from a global financial centre. Now, we might think about the kind of work that exists in Feltham and the kind of work that exists in the city, and the fact you can be there in barely, well, a perfectly reasonable commute. So that working from home and transport connectivity gives a bit of inclination and a bit of indication as to where folks might go to work and the kind of work they might be doing when they get there. Back in October, you as a board will have approved the pharmaceutical needs assessment, one of your statutory obligations. We now have a live version, sorry, we now have an interactive version up on the Data Hub. We've put that there for a couple of reasons. One is that antipathy toward PDFs I've mentioned before. We want to have things that people can interrogate in a way that works for them, and also mindful for next time that you do the P&A, that should make the process a little smoother from our side as well. So a degree of efficiency built into that as well. So that would take us through to a P&A in 2028, I guess, Sterling. Yeah. Brilliant. Okay. Slightly more immediate, we've spent time looking at our warm spaces provision. This is work that we've done for the last 2 or 3 years through the Data Hub. This time round, when you pop online stats.hounslow.gov.uk, you'll be able to see what this warm space provision actually looks like around the borough. This, I think, builds on some of the experience we garnered through working with public health colleagues and with colleagues in community services over the last couple of years, where people don't want, unsurprisingly, to go to a warm space and simply spend their time in a space that's warm. They want to have a reason to go there. And this gives both the residents and interested parties and anyone else who wants to understand what that offer is, an appreciation of what's going on where, whether that's a weekly mother and toddler session in a library, or a chess club in Chiswick, or a knit and natter session. It's a reason for people to go to a warm space rather than simply a warm space that you go to and just sit. to Peter's point about what's happened over years, we've also published the Indices of Deprivation update. Now, I guess as a sort of a policy and insight person, these things are always interesting, but they're interesting primarily because of, for me at any rate, they tell us what we already knew. And I'll touch on the state of the borough in a moment, but the Indices of Deprivation update paints a picture of a borough that's experiencing or has experienced some challenges over the last 4 or 5 years. It's worth remembering when you look at what the IOD does, it takes data typically from various points between 2019 and the beginning of 2025 and melds those indicators together to give you an appreciation of what's going on across a whole raft of indices of deprivation, as the name suggests. In almost all instances, Hounslow is now a local authority area with more pronounced problems than was the case before. There are some outliers. Our health work has improved. We are now, I think, from 152 local authorities, well, the 152nd is the best, as it were, the one with the least deprivation, the least health deprivation. We're 125th, I think. So there's some good progress there. In most instances, though, and again, it really is worth your while popping onto the website and having a look at this, because you can interrogate this to your heart's content down to LSOA and ward level. In most instances, though, things have deteriorated, but we knew that because we knew what happened by way of the pandemic impacts. We knew what happened in terms of the fact that for a long time, the borough has been a location where there were good local jobs, but not necessarily good jobs for locals. And a lot of this plays out in terms of child poverty, which affects the indices of deprivation affecting children. A lot of this plays out in terms of the nature of work that people have, the nature of savings and wealth that people accrue, which then links into the indices of deprivation affecting older people. But I'd urge you all to have a look at that if you haven't done so already, both because it allows us to understand where we've been in 2019 and indeed in previous indices of deprivation years as well, and where we are in 2025. That's a nice piece of work to give us a picture of where we've got to, but it's very much a look back. And so when you look at that, I think it's important to bear in mind that's an amalgam of data that runs from 2019 through to primarily 2023, 2024. And we knew the story of what was happening in the borough at that time, and the data kind of backs up what we knew and what we've done in order to address that. What things will look like when we see the next indices of deprivation, we should be able to see some of the benefits of the work we've done around our equality, diversity and inclusion work, what we're doing in terms of our regeneration approach as well. But for now, as I say, it's worth having a look at that, in no small part because it allows you to be very, very precise in terms of where you're looking and what you're looking at. So I'd urge the board to have a little bit of an engagement with that. The reason it didn't come as a surprise to us, though, is because of the state of the borough. Now, you'll have seen the state of the borough on a number of occasions at this board now, but last year's state of the borough went to borough council in the autumn, but that was our third year, and that painted a picture of what is going on in far more real time than the indices of deprivation. So we've spent time over the last 3 months taking that product out and about around the council and around the borough. I'm back in a different bit of the 6th floor tomorrow, speaking to the funders forum about how they can use this to help understand the nature of need and the nature of opportunity within Hounslow, and how bidders for funds and funders of bids might use that as an evidence base to support activity. So we continue to promote that. Ealing and Hounslow CVS, the internal teams, external teams, and again, we'd urge everyone on the board to tell people about that, because it's a really helpful way to understand how you might commission to address the nature of challenges within the borough. And again, it was something we will continue to promote until we get to the State of the Borough 2026, which will be upon us before we know it. I guess the last element of work that's worth touching upon for the board for now is simply a little bit of refreshing of the range of products we have on the data hub. As I said before, the whole intention was to make sure this JSNA was not a PDF, but it was a live version that people will understand where we are and what's going on. Because of the sheer volume of content we've put on there over the course of the last 3 or 4 years, we now want to make sure that when people pop onto there, they know how up to date the latest data is. So a little bit of housekeeping there that hopefully makes it a little easier for users of that site to understand if they're looking at something that's a month old or if they're looking at something that's 13 months old. When we're back next time, if that's me or Kasturi or Sarah or another colleague in the team, we'll be able to give you a bit of an update on sexual health insight, on social isolation and loneliness, on localized housing rental analysis, which I think is a really interesting topic that clearly has an impact on wider determinants of health and well-being. And we're also doing some work. I spoke about warm spaces a moment ago, but we're also doing some work co-designing our climate resilience approach as well, because we have a situation now, as you're obviously aware, London is a place that doesn't really fare very well in the heat compared to our European peers, in fact, compared to our peers in other parts of the world as well. So we're working with colleagues across the organisation and beyond to make sure that that climate change adaptation work makes sense and it's kind of based on evidence. That's a canter through for the last quarter, Chair. Happy to take any questions as best I can, but I'd kind of default to pointing everyone towards stats.hounslow.gov.uk for more info.
Thank you very much. No, that was very useful. And the interactive data, I mean, we use it quite a lot as elected members, but I don't know how the members of the public, how other people use it. Is it used well? I find it really fascinating, but I don't.
Martin smiles. For a for a website that basically consists of a suite of data and insight, it is surprisingly well used, and it's not just me from different IP addresses, I can assure you. I'll happily share details with the board after I'd asked for this, and unfortunately I couldn't get hold of the numbers for the last quarter for this evening. But we've reported before on volumes, and actually the volumes are quite high. I guess I'd also say the important thing, though, isn't just the number of eyeballs, it's what people do with the data. So it's really heartening to hear that members are looking at the data and using it to inform decisions, as I know commissioners are as well.
Just a quick one from me, Paul. Do you, I know there's a lot of work being done around warm spaces, and we did go to one, didn't we, to promote it. There was lots of activities going on. It was actually in a library. Do you have any understanding of how well they're being used?
So through the seasonal preparedness group, we have updates on what those warmer spaces are doing. I think the next one might be tomorrow or Thursday, yeah. So we can give you, I'd imagine, the most up-to-date data from our colleagues running those spaces after that. I think the story is probably that the learning from the first years was that people, as I alluded to earlier, didn't want to just go to a space to be warm. They wanted a reason to go to a space, and then the warmth and the cup of tea was another thing to stay there. But I can certainly ask our colleagues in communities to make sure you get that data.
It would be interesting to know that. Thank you. Any questions? No. So for the purposes of this committee, this is just an update, is it?
Exactly that,
right,
yeah.
okay,
The board
okay.
has a number of statutory obligations, one of which is the JSNA, and this is just an update on what we've been doing,
Right,
as you well
okay,
know, about
okay.
the last
And in
quarter.
terms of the data and the links, you'll be able to share them in the minutes, or yeah?
More than happy to circulate those directly, yes.
Okay. Okay then, if there's no questions, thank you very much, Paul. We'll move on to the next agenda item, which is a report which we have on every Health Watch report, which we have in every sort of meeting. And are you going to, Peter, you're going to present it yet?
Chair, thank you very much indeed. Peter Goulding, Chair of Health Watch. In the pack, there is our usual report about the patient experience survey. You'll be glad to hear it's 44 pages long, but never fear, I have reduced this succinctly to less than 10 slides for you, and I'd like to do that now. You know who we are. You know that the patient experience survey report comes out quite regularly every quarter. We give you a snapshot. Here is a quick overview, and I'll give you the bullet points so you don't have to read every single word, but it can go to the recording for those of members of the public who are listening. We've done 387 reviews in this particular quarter, 31 visits, and it's quarter two that we're looking at, and we looked at GPs, hospitals, dentists, community services, that's pharmacy, physiotherapy, adult social care, community health. And our snapshot is we've done 274 examples of patient experience in the GP service, and 67% are really positive. All the comments that come in, 67 are positive. Hospitals, we got 63 comments and 42% were positive. Dentists, 17, which is quite good for that particular sector. 70% was positive, which is quite high compared to what people would normally experience around dentists. But it is only 17. It's a small cohort. And community services, 38, and we had 58 positive appointments and comments. Review of GP services, I'll just split it into two. What's really positive and some key issues. The positive, time and time again, this comes out, it's about staff. The staff are great. The doctor's advice is great. The doctor's communication is great. Our challenges, as we know and we've discussed before, is about appointments and the waiting times. But actually, when people are talking to the professionals, they get a very positive response. We've got some comments. They are consistent to what we said before. And waiting times is often looked at, but if you look at that bottom comment, waiting time is quite long. My appointment ended up being 17 minutes later than normal. Now, most of us around the room would say that's not that negative. But for that particular individual, it is negative. It's a comment that was made, therefore we capture it. So you have to bear in mind that we capture the data that patients are actually telling us. I'm not going to go through the PCN access and quality. It is actually very positive. There's nothing really amazingly negative. There's no particular PCN that is an outlier from the others. The detail is in the report if you want to have a look. If we look at the hospitals, we looked at 63 reviews, 42 were positive. But if we look at the reverse, that gives us about 33 that weren't. Again, the positive bit that we're getting is about staff. It's about the treatment. It's about the quality of the treatment. This is actually really good stuff, and we shouldn't lose this. And this is consistent through every single quarter patient experience that we get. So we should be very proud of that. Waiting times is a challenge, and we know that. But let's look at that last point, and this consistently comes up, about 24% communication between services, because we're actually, and we mentioned it previously, we're having a very complex system. We're moving people around. They're being referred to different parts of the system. They sometimes feel the communication breaks down, or they get lost, or they feel slightly disconnected. And that's always going to be the challenge. And we know that. And it's an area that we are trying to do something about, but it's a clear area. If we could make some changes, that would have some real benefits. I won't go through this, but it tells you what you would expect. Staff are patient, they're kind, they get us through the triage. Things are really positive, but we know what the challenges are. If we look at the dental services, this is quite interesting because we've only been doing this for a fairly short time. We did 17 reviews. The positives are really good. The support from the staff, access to services is quite good. This doesn't quite ring true, does it? Because we know that some of the challenges of NHS dentistry, etc. So we have to be a bit cautious, but this is what our current survey is saying. The top issues are appointment availability and costs. But of course, the costs are set by contract, they're set by the NHS. The dentist can't do anything about those costs if it's an NHS treatment. If they are putting private treatment in, of course, a different factor comes out. So we have to be a bit cautious of this, but we do want to focus on NHS dentistry. We're not trying to evaluate private dentistry in this particular survey. The comments, as you would expect, staff are very good, respectful. So we ought to be proud that right across our system, wherever the staff sit, they are giving a very good service. Let's look at the community services, 38. The services we reviewed in this particular quarter: pharmacy, physiotherapy, adult social care, mental health services, community health services. 58 were really positive. Staff came up very well again. Key issues: referral delays, appointment booking systems. I guess we would have to go down into the detail about that particular comment. We have that detail. If you want it, we can provide it. But I think we know that we've got a myriad load of appointment booking systems, and whether the new future of NHS Online would actually solve that, but we know that's not going to come online until 2027. As a pilot, it's not really going to be really embedded till about 2028. So we got what we've got. It's just trying to make the whole system work as well as we can. And referral lists specifically around physiotherapy are extremely long, comes a particular comment. And that has come up before, and we know some of the challenges in physiotherapy that our colleagues can address if necessary. So the recommendations I think are quite consistent that we are giving to this board and to the commissioners each time we issue this report. And the question I suppose we want to reflect upon as we move forward is, what else are we able to do, if anything, about some of these consistent themes? Appointments come up, of course. Improving the transparency of the waiting times and improving information to the patient is always a key. Here is something like the improving the digital screen updates. We've done a huge amount of work on that, but it's still in some places can be a bit of a challenge. You can go in there and you get some really rich information, or you go in there and it's a blank screen. So it's just trying to get our systems working as well as possible. Communication between services, going back to the project we were talking about earlier, we know that's a challenge for all the staff. If we are able to do something about that, that communication between different services, helping to flow the information and the patient around, that would have a real benefit. And interestingly, when we look at information, it's about accessibility of the information. It may well be the information is accessible, but is the patient able to access that information? So we're not saying anything new here. These challenges we know, but it's challenges that we still face as a system. Chair, that gives you a little bit more detail. If you want to drill down into it, that is passed through the commissioning teams, and the report is online that people can look at, 44 pages, and we come up each quarter with a new report. Chair.
Thank you. I've got questions, but I'll bring Claire in. No, Claire, you come.
Mine was just a request, so Peter, it would be really helpful to have some of that detailed information. We're going to be doing a couple of projects this year that will impact on communication and on appointment booking, which we hope ultimately will impact on reducing waiting times as well. That will take a bit of time. So actually having that patient voice very much at the start of that piece of work would be really helpful.
Claire, thank you very much.
And whether it's our service or not, but that general community bit, it's an experience of booking appointments. We know what we need to avoid and what we need to build in.
And Chair, if I could just sort of make this comment, which will be very helpful, I hope. There is this huge pool of data that we've had for a number of years around patient experiences, whether it's GP services or whether it's hospital services, etc. That data sits there. It sits with our current host organisation or the previous host organisation, and it is accessible. And people often come to us saying, have you got data about XYZ? If we got it, we can provide it. Often it will be anonymized. We won't be talking about patient names, etc. But we can provide you the data, and that can assist a specific point or a strategic view forward. That data is there. It doesn't get thrown away. You have access to it. Just ask us the question.
Thank Shaheen?
Thank you, Chair, and Peter, thank you. Obviously, I can only speak for West Mid, and we take Health Watch feedback really seriously. I think on previous feedback, we've had a lot of feedback around the front door, so ED. So we've done quite a lot of work around getting that front door piece right. We've just finished refurbishment of that whole waiting area. We've got wait times up on quite big digital screens, as well as public health messaging now. So that piece is done. And that sort of refurb has really helped us do the front door triaging. So wait for sort of time to triage. The target is 15 minutes. We're down to 7 minutes. We've still got to do some more around wait to be seen by a doctor. So we're working on that. But the last 3 months, we have met our target of what NHS England has set us at 78% of patients seen within 4 hours. But we know we could do more. Pre-COVID, we were doing much better. So there's that piece. We've spent a year looking at wayfinding. So we've done that piece on both hospital sites. I think there's a bit more to do because services have moved, and we've also done that reconciliation of the letters that are going out to make sure that the letters say what area of the hospital it is. The bits that we have still got challenges with, and the bits that we need to do better, is the outpatients area. So wait for pharmacy prescriptions is very long at West Mid. We've got a digital solution to push those out to community pharmacists so that people can go and collect their medicine. So I think hopefully by the end of March that will be in place. So that will reduce the queues at West Mid for pharmacy outpatients. We've got to still do the digital piece around all 8 of our outpatient areas, getting those screens up and working properly. And we've got some challenges around backlogs and wait for first appointments, which we will be picking up through business planning this year to right size and level up the 2 sites around patients waiting for appointments. So quite a lot of work done, but absolutely sort of feedback for West Mid. I will take that back seriously and make sure that that gets discussed at exec board.
Chair, we're extremely grateful, and if there's anything we can do to assist, please reach out to us. I think what I would also say, and it's something we might want to look at collectively as a system, there's some really good work going on, and you've just illustrated some great work that our local hospital is doing, but people aren't necessarily understanding that great work. They're not getting that message. And of course, I know you're wanting to communicate that, but people just generally don't get their news from visiting your website. But maybe collectively we could do more to communicate some of the good improvements that we are making. For example, the A&E wait times, etc., for triage is really quite important. It's a concern for a lot of people. And we've worked very closely with you in our 0 to 4 survey recently, where we're working with your consultants in A&E, etc., to see what we could do to help you. So I think there's more we could do to communicate the good news.
Yeah, I do take that on board. I mean, from my personal observation, unfortunately, I had to go to A&E on Friday night. It was not me, it was my mother, and we did wait a long time. But I did see some improvements. And one of the things that I did notice, which I thought was quite helpful because you're there for such a long time, was the screens with the information. I thought that was very interesting, actually. I did take down some numbers. It's only because I'd probably looked at them for about 4 hours. But I realised that actually that's good. Is that new? I thought that was
That's
really
all
good.
new.
And I do really pick up, and I have to keep saying this again because it's important. The attitude of staff is brilliant. It's so good. And I know it is, I could see that everybody was rushing. I could see that it was busy, but the care was, that was provided was really excellent. And I think that's really important because people know they're going to wait, but what they don't want to do is be waiting and don't feel that they've gone away with with anything useful. But yeah, no, that was good. Thank you.
Understood. We'll take all the feedback back to the hospital.
Yeah, and the obviously negative point, picking up prescriptions, hideous. Yeah, sorry.
And picking up the phone
It
and
is.
not getting
It
anyone
is,
on the
yeah.
end of it. That's a concern for
Improvement to
us
be
as well.
made. Yeah. Too. Yeah.
Hi, Peter. Just on the dentist access, I presume that you were speaking to people who are in the dentist, so access wasn't a problem. That's why it's 11%. So it didn't reflect the population that can't access. I was just assuming that, so I was just checking my assumptions are correct.
Chair, we've had discussions with a local dental committee. What else could we do collectively, and what could they do about publicising their services? Because there is this confusion around NH services, private dental services, etc. They refer that they can't really do much locally as a dental committee. They refer it back to the ICB, and it is an issue around pure communication and understanding the contracts and the costs, because they're laid down. If you have this type of treatment, you've got to pay on the NHS this amount, and it's a fixed cost. The dentist doesn't have any say on that, but it's about communicating that. And I think there is an area that we perhaps need to look up more around this dental, because we're getting some positive feedbacks, but I'm not sure whether that's really reflecting the residents' experience around dental services. I think it's much better than other areas of the country, definitely. But do we really know what that experience is? I'm not sure, to be honest.
Just might sound like a silly question, but just reflecting on the dentistry, do you only collect information from those that have had received a service? So, for example, those that are having difficulty accessing dentists wouldn't necessarily be reflected in what your report is showing is those that have actually received some form of dental treatment. Yes. Not those that
Chair,
have
I'm going to make a comment, and if I'm wrong, somebody will hang me for it outside the meeting. But this will be going into the surgery as we do with the GP surgery, and we are putting some questions to somebody that's in the waiting room. That's our standard practice. We could be commissioned to do a piece of work that looked at other ways of collecting data around people's experiences of dental services. We could do that, but that would be a matter for the commissioner. That may well be very useful, because we know what the national picture is. We know that's not going to be that much different within the borough, but we may, as a borough, be much better than others. We don't know, and we don't know what the unmet demand is. But I defer to Stephen, in terms of young people. We talk about 0 to 4. We talk about their teeth. We talk about breastfeeding. We talk about, if you talk to a dentist, if you're putting the wrong food supplements to babies, it can have a real impact on their teeth. So this advice can be given to dentists, to patients, etc. But whether it's an area we need to look at, I don't know. I defer to others.
Stephen, did you want to come in on?
Yeah, I was trying to whisper down the table to Sheena, but it's too far to whisper. Do you record presentations at A&E Paediatric for dental things for children? Do you record presentations at Paediatric A&E for dental matters?
I think we do. I don't know what that volume is.
That in itself might be worth just a look at.
I just also want to pick up on something about physiotherapy waiting time. Is anything being done about that? Is there something?
it's a demand and capacity challenge. The referral numbers have gone up. The staff number hasn't. But they are trying to find different ways rather than the traditional one-to-one. So they've done a range of community days, which is focused particularly around back pain referrals to particularly where it's a kind of a working age cohort, to then cover a range of aspects of their care, including back to work conversations. So, we're trying to engage people in different ways, which will then help with those to reduce down the number waiting for those who definitely need a one-to-one.
It'd be good to get some more information about that and just advertising that amongst the community, because I think that is an area where it's brought to my attention, and it'd be good if there are other alternatives to people waiting for physiotherapy.
Yes, and of course, previously, years and years ago, you would have been referred to physiotherapy and you would have had a one-to-one session, etc. And of course, now we've changed this. So often you get referred, there is an assessment by the physio. You would then be given information in that cohort that says, these are the exercises, etc., that you do. You actually don't need physiotherapy. You need to follow this plan. And there will be a call back later on 6 to 8 weeks. I've gone through that process could be better. I think it could always be improved, the information that you give and the follow-up, because it then relying on somebody doing that themselves and exercising in the way that's going to give the benefit, so it doesn't give another referral back to our GP colleague.
Any further questions, comments? No? Okay, well, thank you very much for the report. And obviously it gets noted here and then it gets sent to all the different places. If there's Peter, if there is further information that we want, like some sort of statistics, etc., for the recommendations, they're all available if anybody wants them. Is that correct? Yeah.
Yes, and if you've got any specific questions or queries, come to us and we will tell you whether we got some information to help.
Okay, thank you. Okay, then in that case, I will move on to the final item on the agenda, which is AOB, and nothing's been brought to my attention. In that case, if there's nobody's brought anything to my attention here. In that case, date of next meeting is the 23rd of April at 4 o'clock, which is our usual time. Yeah, apologies for the time confusion for this meeting. Okay, thank you very much, and thank you, and have a good evening.
Thank you, Chair.